So as he's walking up to the stage, this is Scott Wieters. He is an ER physician. He's also the med student clerkship director at Scott & White up in Temple, Texas. A little story that a lot of y'all may not know about Scott is when I was a third-year med student doing my rotations in emergency medicine, Scott was my third-year resident. And one of the many reasons I went into emergency medicine was because of him and his wife and the way they mentored and the way they taught. I wanted to be just like him. It's really, truly an honor to be standing up here next to him as a colleague, a friend. We have discussions all the time, and just great all-around guy, great educator. For those of you on Twitter, he goes by the handle @emedcoach. Be sure to follow him because he puts out some amazing, amazing pearls. Scott, thank you for coming down to the Rebellion. Thank you for doing this.
Thank you, brother. All right. I'm going to start off with a video. Since we're in Texas, we're at the Pearl Stables. I wear boots when I speak. San Antonio's my home, so enjoy this.
I said throw down, boy. Oh. You gonna do something or just stand there and bleed?
And that's the question we have today. When patients come in on anticoagulants and they're trying to bleed to death, are you going to do something or just stand there and bleed? So let's try to answer this question. Again, I have no disclosures. Salim has shown you I'm wearing everything we've got. I do tweet at emedcoach, and my email here is at wieters@gmail.com. So my story starts off with Gary and Kay. Now, these are the parents of some of our best friends, and Gary's a retired Baptist preacher and a cowboy. He lives in Salado, Texas, which is deep in the heart of Texas, and one day Gary's out riding the range, just enjoying his retirement. And a little critter kind of skeets around, and his horse gets spooked, and he gets thrown from his horse. And he's hurt, he's injured, but he's a retired Baptist preacher, he's a cowboy. So at the begrudging request of his wife, he limps into the emergency department and responds that his pain is at a level 1, which nobody ever says pain is a level 1, but this guy does. And he waits patiently for many hours until he gets seen. Well, we get him worked up, and we do find out that Gary's not doing as well as we had hoped. He had multiple broken ribs, he had a hemothorax. As he became a little less alert, we recognized that he had a subdural. And as you can guess on the note of this talk, what is Gary taking? He's anticoagulated, folks, you're right. So Gary did make a pretty good recovery, but he had great doctors that day. I was not his doctor. He had a really good team. And they put him back together and got him back on his horse. So today I want to talk about the not-so-new oral anticoagulants. They're not new anymore. They're kind of old news. But they are direct, they are target-specific, and they hit some things where you don't want to be hit. So I'm going to focus on not Coumadin, not heparins, all these things, but I'm going to focus on the newer agents that we might not know as well. So the 10A inhibitors and then also the direct thrombin inhibitors are where we're going to spend our time. How do these work? What do they do to us? And then what do we do to reverse them? There's some really new news coming out that you probably have not ever heard at a conference. So we're going to get this going. You know, I think the Joint Commission really wanted to do something worthwhile. They would stop looking at sepsis metrics, and they would probably hire Lawrence Fishburne to counsel people before they started taking some of these anticoagulants, right? Because who's seen someone bleeding to death from one of these new anticoagulants? Yeah. If your hand doesn't go up, you probably ain't working. So they're out there. These people are coming into our departments, and for good reason. You know, very good-meaning cardiologists put people on this for AFib, and very good-meaning people help with this, but these can be dangerous. They require good counseling. So the first thing I think we need to find out is when did you last take this stuff, and understanding the half-lives, because half-lives matter. If you go to 5 half-lives of these medications, you can find out that good old rivaroxaban may be your best bet if you're bleeding to death, because it's only going to last about a day and a half. So if they didn't take their medicines, that might be important. The other thing is you need to be aware of their renal function. If our renal function is impaired, either by its chronically creeping or maybe they've got acute renal failure, this stuff's going to be a lot more potent. So the two things I think you need to consider, when did you take this and what kind of medicine is it? And then how is your renal function doing? Those are really going to help us understand the potency of some of these medications. I love this slide because if you want to measure some of these new anticoagulants, it's tough. You cannot use a tape measure to measure a drug level. You just cannot use that to measure the drug level. And I love this slide because NOACs are hard to measure. Who has, let's do a show of hands, who's got eccrine clotting times in their department? Who uses that routinely? And none of you should be using this, but that's the gold standard for measuring the dabigatran. How about thrombin clotting time? No hands? How about, all right, anti-10A levels? This is kind of new. Some people might have this. We've got 1, 2, 3. I've got this. We'll talk about how helpful that might or might not be. That's good for the 10A inhibitors. What about who's using TEGs to measure anticoagulants? About the same, or maybe 5 hands up in the room. Okay, all right. Now, we probably don't have drug chromatography for these things, but we all have, who's got coags? Yeah, everybody has raised their hand. You've got coags, okay. We'll talk about the useful nature of those. Sometimes it helps, sometimes it doesn't. So I ran a anti-10A level just this last week on a poor lady who was bleeding from a GI bleed. And here's what my 10A level read, and I took off all the important things for EPIC. Our IT people are very happy. So this is only validated for unfractionated and low molecular weight heparin. So if you're ordering a 10A level on your patients who are taking some of these medications, it must be calibrated against the actual agent they're on. It's different for rivaroxaban, it's different for apixaban, and heparin and low molecular weight heparin are all different. So be careful when you're talking about calibrating these agents. Anti-10As are hard to find. Make sure your machine is calibrated before you're using this. Now, you may have heard people, I have seen on blogs, I have seen people speaking, saying that if the PT is elevated, well, everything's fine. I mean, well, you're anticoagulated, but if the PT is not elevated, everything's fine, and that's not the truth. The PT being elevated means that you're at the 75th percentile of active drug level. If it's normal, you could still be at a 65, 55, you could still be at a very potent anticoagulant level and not know about it. So if the PT is normal, you're still not safe. Don't think that this person is fine. They could still bleed to death. Same with PTT. Dabigatran tends to make the PTT higher when it's at the 75th percentile, steady state. When it's normal, you cannot trust your coags. Who knows what this Latin saying means? In vino veritas. Anyone? In wine is truth, the man says. He's exactly correct. In wine is truth. So that's what this means. And I'm a simple person. When it comes to understanding TEGs, I can't look at it. I just see a bunch of ink blots and butterflies and things. But this is TEG for dummies. It's a great slide I found. I kind of tweaked it a little bit here. But if you're normal, you're like the brandy glass. Maybe you want some champagne or wine. Maybe you need some antifibrinolysis with TXA, or maybe you need platelets. But the problem with this is, and I'm not a TEG expert, believe me, I'm not up here to tell you I know a TEG backwards and forwards, because I don't. I know my limitations. The people that do know say that you cannot use TEG for looking at the new oral anticoagulants. So I hate to break your glass, but TEGs just don't work. So the take-home point number one, NOACs are very hard to manage and measure. They're very tricky. And the common coagulation parameters can lie. In summary, PT elevated, you're probably on board. You've got anticoagulant on board. PTT elevated, you've probably got dabigatran on board. If you've got a really ugly-looking TEG, okay, it's a really big glass of wine, you might be anticoagulated. And if your anti-10A level is calibrated, you probably have the right thing. But those are the pitfalls that you can fall into when you're trying to measure these difficult, tricky new drugs. If there's one thing in Texas we can do is if you get on the wrong road, we know how to turn you around, and we can confuse you by doing this. So there's a lot of reversal agents that are out there. I won't be talking about things. You're not going to be giving oral charcoal to a person who's dying from a head bleed that you're taking to the OR. I don't know who's doing these kind of things, but nobody's giving charcoal to these patients. We're not going to dialyze people and stick in a huge garden hose into someone who's already bleeding out for quick reversal. We won't talk about some of these other agents, but I will talk about what I think is important in our short 20 minutes together. All right, I want to focus on our 10A inhibitors, and we'll talk about prothrombin complex concentrates. So I'm talking about 4-factor Kcentra, 2, 7, 9, and 10. Who has this in their shop? Most of you should probably have this if you're working in a larger institution. This is about maybe 5 to 10 years old, and most people are recommending this right now if you do have a 10A inhibitor on board. So remember, PCCs have 2, 7, 9, and 10. They are the inactive factor. They have not been activated yet. Don't forget that these also contain protein C and protein S and a little pinch of heparin, a little seasoning of heparin. So you have to be aware of this. So this is not a true procoagulant. It's got a little more balanced of a process, but it is going to reverse people. So some people are recommending this. The other thing we've got out is FIBA. Anybody got FIBA out there? Factor VIII inhibitor bypass activity. This is what they give to people missing factor, hemophiliacs, and others. Now this, in contrast to PCC. Now this is full octane, unfiltered, organic, fair trade, wholly, it's the good stuff. So this is full octane procoagulant without protein C and protein S, without heparin, and it is the activated factor, not the inactive. It just comes ready to go. So this is very flammable stuff, very procoagulant. And because dabigatran is so far down on the coagulation cascade, you're going to see experts recommending this over the PCCs. All right, let's talk about a few little pieces of data here. What else do we have? Yeah, FFP. We've all got FFP, don't we? You might see people talking about using FFP to reverse these agents, but let's talk about FFP and what it really is. It takes about 30 cc's per kilo of FFP to get on board to somebody to bring them down to the INR of FFP, because you know what happens when you send a bag of FFP to the lab and get an INR on it? Do you know what it is? It might be 1.5. Some people say as bad as 1.7. You can never get down to normal with FFP. And you've got a 1 in 300 chance of getting taco, trolley, transfusion reactions, and type and screen. So FFPs might not be the perfect agent to get people back to normal again. Next, let's go ahead and focus in on a couple of the new agents that are coming out. Adnexa Alpha was just released last Friday. Yeah, so this blew up my talk. The FDA just approved Adnexa Alpha for use in MARCA just last Friday. Cereterapag is a new agent that's not yet FDA approved. That's why it's got an asterisk. We'll talk about that. And then idarucizumab is going to be a killer for dabigatran. So Adnexa Alpha works on the 10As. So this is an antibody that eats up the drug so that the drug can't then get into our coagulation cascade and kind of protects it. Cereterapag is actually the shotgun. I'll tell you about this later, but it hits everything. It's supposed to be sold as the 10A killer, the direct thrombin killer, heparin, Lovenox, whatever you knocks, it's going to kill it. So this is supposed to be the cure-all for these things. Still in animal and human trials, not ready for prime time yet. And then idarucizumab, this came out in 2015. This is an agent that's used to direct thrombin inhibitors. And that really binds up the activity of these drugs as well, protects your coagulation cascade so that it can do its job. Okay. The other thing that we might not consider here is that when plasminogen comes in, it comes and eats up our clot. And that's what fibrinolysis is. And later on this morning, I'm going to talk about another drug that I think you need to be aware of called TXA, tranexamic acid. It binds to the lysine binding site on plasminogen and basically stops plasminogen from going and eating this clot. So that might be something to consider. And there's no real big trials on this, but a lot of experts recommend this. This is something you're going to see on guidelines and policy statements from organizations and hospitals. And it's something that, again, in my research, I would probably recommend if you have a person that's bleeding to death on an anticoagulant. So let's go back to Gary. He's in our ED. He's bleeding. And let's say that Gary is dancing with the devil this day. He's taking dabigatran. I don't see a lot of people on dabigatran because it's got incidents of GI bleeds. It's longer lasting, very renal dependent. And so you're really taking some risk. You're dancing with the devil when you're taking the dabigatran. It might be right for some people, but this is a kind of a risky medication. So let's focus in on that direct thrombin and find out what we do to address this. And I'll talk about the background. This got approved by the FDA back in 2015. And they released this Pradaxa. Idarucizumab is the name of the medication. Again, it's an antibody that binds up the dabigatran and stops it from attacking the direct thrombin. The way they found this is they just found 47 dudes minding their own business who signed up to get anticoagulated and then pumped in some drug. And I mean, I don't know if you got a lot of free time, but that's not some study that I'm going to sign up for. But apparently there's a lot of interested individuals out there, and they said in about a few minutes that this made things look better on the labs. So good for those 47-year-old guys. I don't think they died, but good for them. Now, then they did a little more advanced trial. They took a bunch of people and they did some procedures. They did some lines. They did some minor surgeries. They did some LPs. And they found out that after they gave the reversal agent, idarucizumab, that they had some normal hemostasis using a validated hemostatic model of grading. So they did have some good success in 2015. Moving on along, they had another trial that was done in 2017, which was a prospective, open-label study, not blinded, not comparing different arms of other treatments, but they found people that were bleeding to death on this agent, and they went ahead and gave them some idarucizumab and found out that at about 2.5 hours on average, these people stopped bleeding. Now, they didn't talk a whole lot about this. You have to really read the trial well to find out that it took 11.5 hours for a lot of people to stop bleeding. Some people bled right away and they quit, and everything in the middle. So you got to read some of the fine print. So this is not a perfect agent. This is limited data. We're not sure what to think about this. In the same trial, they also included a couple of people that were doing procedures. The clicker will help us. We can get forward. 202 patients with procedures. And again, 93% of those people with the minor procedures did receive some hemostasis. There might have been some conflicts of interest. I just didn't have enough slide real estate to show you all of them. But these people were deeply involved with the industry, and I think that's something you just need to be aware of. I'm not throwing rocks, I'm just showing you a slide here. So what we have is that these are some trials that, are low-powered. They are sponsored by the industry, and their clinical outcomes were not compared against other standards. So right now, this is kind of all we have, but we need more data before we can really sell this as a true, proven, accepted pathway. So what will I do today if someone comes in bleeding on dabigatran? I will be using idarucizumab. It comes in 2.5 gram vials. You're going to give 2 of those vials at 5 grams. And I will probably also give some tranexamic acid to this person, especially if this happened within 3 hours, and I'll tell you more about that in a few hours later on. If you don't have that, I'm going to slide ahead here, you might consider giving that FIBA to this person. The dabigatran is so far down on the anticoagulant trail that it's going to be tough with the PCCs to address that. So a lot of experts are recommending to give the FIBA. All right, next we'll move on over to our 10A inhibitors. Okay. Move on to the 10A inhibitors. Who's seen people on 10A inhibitors? These things are out there a lot. Some of you may be even taking these things, but they're out there in the community, ready to go. Next slide, please. Okay, at most conferences, I would spend about 30 minutes talking about every single trial that's gone on for these agents, but this is rebellion, so let me just give you the facts. When people were given this, they looked better with their labs, okay? So people on 10A inhibitors who got PCCs and FIBA, they looked better with their labs, and I can just save you the hard work of looking through these 45 studies and tell you that these case series, that's what happened. A little bit more data here. These are actual patients that were bleeding on 10A inhibitors. Most of them had head bleeds. And what they did to these folks is they gave the high-dose PCC, that's going to be 50 units per kilogram, and they looked to find out hemostasis occurred in about 70% of those, and 18% died. Not compared against another therapy, not studied in parallel with any other pathway, but that's just what they did in their case series. Another trial came out around the same time, and these were people that were given FIBA, only 13 patients on 10A inhibitors. So these people were noted, some got better, some got worse, some people did the same thing. And I have to point out that case series are to evidence-based medicine as Facebook is to news. I just don't know what you can do with case series that weren't compared against other therapies. I mean, talk about it on Facebook, talk about it in journals. I don't know what to do with this data. But that's kind of the level of evidence that we've got out there on reversing the 10A inhibitors using PCC and FIBA. Now, this next few slides are sponsored by the official comfort pet of anticoagulated patients. Yes, that is the Chinese hamster, ladies and gentlemen, because in the female Chinese hamster ovary, they found our next drug. I mean, you got to look hard. You got to be a good scientist and look under every nook and cranny to find something in a Chinese hamster ovary. But that's where they found adnexate alpha. So you know it's a 10A drug because it's got the XA. So this is the new drug that the FDA just approved. May the 4th be with you, adnexate alpha. You're a lucky day. But they basically approved this drug based on some limited data. I'll show you kind of the background here. And this is out. The drug should come in June. I don't know the cost, but you can plan on the price of a small sedan. It should hit our hospitals 2019. We'll see. I don't know. The way they found this is they did the Annexa A and the Annexa R trial for apixaban and rivaroxaban. Again, we're finding random dudes on the streets who want to get anticoagulated and have anticoagulant drugs pushed in their bloodstream. They found these people, they did it, and that's where this drug study came from. And apparently, it reversed it by looking at people's labs. Nobody bled, nobody died, nobody's head fell off, but they had a good day, they got paid. This is the better trial here, the Annexa 4, and this is ongoing. And they presented a biopsy of this study in 2016. And what they found is that they had about 67 bleeding patients, and most of these people had bleeding cessation at 12 hours. They did have some thrombotic events, and so that's problematic. Again, this is open label. This is not comparison trials versus different arms. This is just giving the drug out to people and just seeing what happened. I mean, you just threw it up in the air and found out what happened. So that's what we're talking about in 2016. Now, the reason the FDA got paused by this is they wanted more data. And so at the ACC conference in San Diego, they just presented 200 patients more that were on this trial. And right now, they're at about 227 patients. So right now, they're saying that it actively reverses patients as far as up to 12 hours. The dosage for this is going to be different based on which 10A you're getting. It's a bolus, and then it's a drip. And so that's what they're doing in these trials. And that's the level of data that we're dealing with, folks. I mean, it's apparently that easy to get something through the FDA. So what is my summary right now? If somebody's coming in with a 10A inhibitor and they're bleeding to death, and I'm not trying to talk about who to choose to reverse. I'm talking about you've made that decision to reverse them. What are you going to use? So we're going to talk about trying to find some Adnexa alpha. And I'm going to be giving a gram of tranexamic acid if I can find it. If I don't have Adnexa, I'll probably be giving the prothrombin complex concentrates. And I'm going to choose a high dose, the 50 units per kilogram. And that's what most people are recommending these days when someone comes in for a life-threatening bleed. Quick side note, the shotgun, Seraperitag, this is supposed to hit everything. So again, if somebody's bleeding, you just pull out the shotgun and you give them this medicine, apparently everything gets better. I don't know if that really happens or not, but apparently in small Chinese hamsters, they live, okay? We'll see if it works on humans, but we don't know yet. That's still not approved, but something coming down the pipeline or down the barrel of the gun, I should say. Well, congratulations. You've now become an expert. You know everything there is to know about the new anticoagulants, which aren't so new again. But you are now an expert in this field, so I congratulate you on this. I'll give some summary slides, I'll tell a story, and then I'll wrap it up for question. My summary is that these are really hard to measure. You got to know the way these drugs act. You got to know when they took them. You got to know which labs help you. If it's an elevated PT on a 10A inhibitor, it's probably active. If it's an elevated PTT and you're on dabigatran, it's probably active. If your TEG looks really funny and the lab tech is scratching their head saying, wow, this looks weird, they're probably active. If your 10A, anti-10A levels are calibrated against that drug, you might be able to tell the difference. So these are some pitfalls. Be careful with the measurement. My quick summary slide, if you're the person that takes pictures of things and posts them, this is probably the summary slide you want. If someone comes in on a 10A inhibitor, if I can find Adnexa alpha, now that it's FDA approved, maybe this summer I'll find it and give it, along with TXA. If I don't have that, I'll give some PCCs and TXA. If someone is dying from dabigatran, I'll probably try to find some idarucizumab, and I'll give some TXA. If I don't have that, I'll probably try some FIBA, and that's what I'll do. So folks, I hope that you've come here. I hope you've gained information so that when Gary rides his horse into your emergency department and he's bleeding to death, you're going to know how to take good care of him. Because I know that's why we're here, is to take care of our patients well. And so I challenge you to leave this place with this information. Go out, do great work, and care for your patients. Thank you.
Do we have any questions for Scott? Just so everyone can hear.
Okay, so you have a guy that comes in your ER with a PE. He's admitted for a few days. You treat him, send him home on apixaban. Comes back to your ED 7 days later with a head bleed. Neck pain, which you determine as a head bleed. Say your facility doesn't have any case entry either because you don't carry it or you just used it all on the other patient. How do you feel about the three-factor PCC with FFP?
Wow, I think that's a great question. That's a nuanced question. You're not going to find evidence to support one pathway over the other. I will say that you will see the four-factor PCC being more advantageous in some of the trials than the three-factor PCC. They've done those trials mostly on people that were on Coumadin that are trying to be reversed. And there is clear advantage to using the four-factor PCC over the three-factor, and that's why we kind of recommend that. If you've got the three-factor PCC and they get a head bleed and that's all you have, and they're herniated, I'm not talking about the person that might have a little punctate lesion that's maybe a little bit dizzy. I'm talking someone that you're needing to intubate, they're bleeding, we're trying to get neurosurgeon. I think we're talking about providing aggressive care. And if you're at that point when they're painted into a corner, I think you've got to give that aggressive care if that's all you've got. No one's going to fault you for providing aggressive care to a patient, but you've got to be in that kind of situation. Good question.
Any other questions?
It was a nice presentation, thank you. Just based on the studies that you review in terms of the side effects of these medications, the thrombotic events, what's the most common thrombotic events that you have?
So the most common thrombotic events that you're going to see are going to be thromboembolism. Yeah, that's clearly the most common thing you're going to see. So most of these people did get PEs. But again, you're talking about people that have Chad's VAS scores that are like 317. They're high scores. They're old people. They're people that have probably had PEs, one of the things we're looking at is a guy got cancer. He's 80 years old. He's terminal on hospice and bled, and they gave him one of these, and oh, look, the guy got a PE. Wow. So it's tough to say when you're talking about the nuance of separating things out, but the most common thrombotic event will be a PE.
Thank you, Scott.
Thank you.